Thank you guys so much. It's a real honor to be here, especially the last session of the afternoon. What a fantastic day this has been, and a great way to spend a Friday. And again, I'm honored to be presenting to you. Now, in full disclosure, the organizers asked me to give updates on all GI cancer. And it's a long organ system. It goes from here to, and I decided, this was me taking executive sort of privilege, it would make the most sense, it would be the highest impact if we talked about colorectal cancer. It is the third most prevalent cancer in the United States. And one of the things that really strikes me as an oncologist is just how well the women's health movement has addressed things like breast cancer. And I often see women in my clinic, and I am a GI oncologist, I'm at the very end of the care continuum, women who have dutifully been getting their mammograms, pap smears, and HPV testing, and have never had a colonoscopy. And that, to me, is a preventable tragedy, because everybody has a colon. Hence, I'm going to focus on the colorectal. One of the things that also strikes me is when I meet patients in my clinic, they inevitably ask two questions. First one, Doc, what's my stage? Second one, Doc, how long am I going to live? Those two questions are very much related, and to answer them, I have to think about stage. And one of the things I wanted to tell you is that all stage 4 disease is not created equal when it comes to colorectal cancer. When I was doing my fellowship, I had an attending. He said, Mark, always ask yourself, are there too many weeds in the garden? And what he meant by that is we get a gestalt. When we meet a patient and we look at them and we look at their scans, we have a sense of, is this person just completely overrun with cancer? Is their liver, for instance, overgrown with metastases? Or is there a single metastasis that is putting that person in the stage 4 grouping? And that's really, really key that we ask that, because within stage 4, we have oligometastatic, and then we have widely metastatic, and we really have to think about that. The other thing I wanted to tell you is the colon is not one organ. If you want to be really cheeky, the next time you're talking to an oncologist, you can ask them, hey, doc, how many organs is the colon? And there is a deliberate subject-verb disagreement there. It's 2 organs put together, okay? When we're in utero, the hindgut and the midgut fuse in the transverse colon. And that embryology matters decades later. So side matters. Even once the cancer has metastasized, you absolutely have to know, did it start on the left side of the colon, or did it start on the right side of the colon? They are different organs, and they are different diseases, and I'll show you why. So this was a really interesting trial. This actually goes to show you, be really careful sometimes calling a trial negative. This trial was published in 2014. Now, the schema was very, very simple. It said, okay, first line, metastatic colon cancer. Dealer's choice chemo, should we be giving bevacizumab, or should we be giving cetuximab? So it was designed to be a study of biologic agents, and this was the initial result. You cannot fit a laser pointer between those curves. This is a negative trial until 3 years later, a very smart investigator, Dr. Vanook at UCSF, said, hold on a second, what if we look at this by side? So the biggest advance, or one of them, in colon cancer over the last decade, left is different than right. And this is how different. So what I want you to pay attention to is the top curve and the bottom curve. These patients are getting exactly the same regimen. They're getting chemo and cetuximab, and their survival distance is 20 months by left versus right. Left did great, right did not. Basically, you should not be giving right-sided colon cancer cetuximab. They do horribly. So the other thing to think about is what is the minimum amount of information that you should have treating a colon cancer patient? One of the things I like to say is 80% of the oncologists in the US are not like me. I treat only GI. Most oncologists have remarkable breadth. So for instance, they might go from a breast cancer patient to a lung cancer patient to a prostate to a colon. Many of you probably do exactly that. And it's striking to me, no oncologist on earth is going to treat breast cancer without knowing ER, PR, and HER2. And yet, as I just told you, we do the bare minimum to understand colon cancer and the differences in the disease. So one little kind of maybe dirty little secret about oncologists, if we're trying to make a decision about treatment, there are 3 places that we go. NCCN guidelines, up to date, and Google, okay? It's true. And I'm not saying any of those are bad, but I always think that the NCCN guidelines matter because they actually dictate what most oncologists do, especially if you're the kind of oncologist where you're seeing every type of cancer. This is what I really, really like about the NCCN guidelines. The very first bifurcation here is, can the patient, not the disease, can the patient handle intensive therapy? So for all the talk I'm going into right now about where's the tumor and what does it look like in terms of biomarkers, actually the most important question is what's the patient's performance status? Because we can be very, very aggressive or we can be less aggressive. So that's also important to take into account. This slide still takes my breath away. So this came out in the New England Journal at the end of 2020. What this slide says is there are some patients with metastatic colon cancer who you can treat without a drop of chemo. That is an unbelievable statement. When I started my career, I can't imagine being up here on a stage saying that, and yet it's true. So this is Keynote 177. This is looking at pembrolizumab in patients with MSI-high colon cancer. And so the pembrolizumab arm is the blue curve. And you'll note there is an initial drop-off where the patients who were getting chemo, the red curve, did better. How do I explain that? I think those patients were on the verge of visceral crisis. Too many weeds in the garden, on the verge of liver failure. Those people need a rapid response. But if it's not those people, you can actually treat most of these patients with pembrolizumab and look at that long tail of the blue curve. It's not perfect. Not everybody's living forever, but it's remarkable to look at that. In fact, the professor I had at Mayo who first taught me about colon cancer wrote this editorial along with the New England Journal article basically saying that he thought this was the new standard of care. And if we can avoid giving chemo as oncologists, we should absolutely avoid giving chemo. And this is really the new revolution of immunotherapy. You know, when I started training, I was taught there's 3 ways to attack cancer. You can cut it out, surgery, you can burn it, radiation, or you can poison it, chemo. And now we have a 4th, which is immunotherapy. However, we are missing the opportunity to give all the patients immunotherapy who need it. So this is a study that I did along with colleagues, including Dr. Chris Liu, who I think works with some of you here, one of the best oncologists on the planet, let alone in Colorado. What we find is that only two-thirds of patients are even being tested for MSI-high status, which means that we are missing a third of them. That is absolutely unacceptable. I'll go back to breast cancer. What breast cancer patient, what breast cancer oncologist would treat without knowing biomarkers? We have to be testing this. This has to be an opt-out test, not an opt-in. The example I give is organ donation. So in Scandinavian countries where you have to opt out of organ donation when you're getting your driver's license, they have a remarkable rate. Something like 90+% of their citizens are organ donors. Here in the United States, where in many states you have to opt in, we're in the teens at most. So we need to be opting out of these tests, not opting in, and there's really no reason to opt out. Okay, so now I'm going to tell a little story about my family, and I'm telling you this because it is the perfect example of how some advances in oncology are so big that they hit mainstream media at the same time they're being presented at conferences, okay? You also have to know a little bit about my mother. So I'm an only child. My mother is a widow. She's a fiercely independent Scottish woman. She is not a doctor. She does not follow me on Twitter, but adorably, she Googles what I tweet every day. And she's also a big reader of the New York Times. So I was at ASCO last year. It was Sunday morning, which is typically kind of the day all the big stuff comes out. And my phone starts ringing, and it's my mom. The other thing you have to know about us, we're British, so we don't emote a whole lot. And we basically schedule a call every week. So if she's calling me and it's not in that designated time window, something is very, very wrong. And I was like, oh my gosh, this is an emergency. So I'm sitting there in an auditorium like this one. My phone's going off, and it's my mother. And I was like, oh man, this is bad timing, but I got to take this. So I run out of the auditorium, and I was like, Mom, what's going on? She goes, Mark, have you heard about the rectal cancer? It's gone. And I was like, have you had rectal cancer? And you haven't told me. I'm a GI oncologist, and I'm your son. She goes, no. It's in the news. All the rectal cancer went away. And she was referring to this New York Times article that was announcing what I was there hearing. And I said, Mom, I'm actually here right now listening to what you're telling me about, so if I could get back to it. She said, yeah. You get back to your science fair, son. And it's true. And I was like, well, it's not exactly volcanoes with baking soda and vinegar. But, and it's really remarkable. So this trial, it was front page news deservedly. So this is Sloan Kettering. I'm just going to do the rest of the talk in a Scottish accent, if that's right. My American wife says it's way more interesting anyway. So just because I don't have more than one wife. I have a wife who's from America. Anyway. So so they had a dozen patients, which normally is not a big trial, right? We'd say, oh, sample size is too small. A dozen patients, all with MSI high rectal cancer, who otherwise were going to go through chemo, radiation, and surgery that was likely going to give them an ostomy. And they got immunotherapy, and none of them needed any of that because they all responded. This is unbelievable. 12 complete responses. They even show you on the right there's PET scans and endoscopies, and it just goes away. And as far as I know, actually, I think none of them have had recurrence or needed any of this other stuff. So we're at the point now where, again, we absolutely have to know MSI high status, not just in colon cancer, but in rectal cancer. All right, so there's a pretty famous physician surgeon, Dr. Gawande, Atul Gawande, who wrote this book about the checklist manifesto. Many of you have probably heard of it. And basically what he's saying is if you're going in the operating room, you have to follow a strict standard to keep the patient safe. It's kind of like the aviation industry. You know, plane crashes, thankfully, are very, very rare now because pilots and their crews go through all these checkpoints. And we should be doing the same. So I'll point out to you, we should be doing this exactly like Dr. Gawande says in colorectal cancer. So sidedness, I've already convinced you of that, hopefully. You have to know KRAS, NRAS, and BRAF. You absolutely have to know mismatch repair / microsatellite instability. You have to know HER2. Now, the ones that are a bit iffy, and that's the reason I'm not going to elaborate too much on them, tumor mutational burden and CMS, which here stands for consensus molecular subtypes. We don't really know what we're doing with these yet, so I put question marks by them. But the biggest check mark of all is patient fitness. Do you think this patient can handle chemo or not? And remember, there's some people on this list who won't even need chemo. So if you've got an MSI high patient, you may never need to give them chemotherapy, and that makes the fitness equation look a little bit different. So now let's switch to adjuvant. When I was at Mayo and they first taught me about adjuvant therapy, I thought, how am I ever going to sit down with a patient and convince them to do this? This is the hardest sell in all of medicine. I truly believe that. Because what you're telling the patient is they've had surgery. The surgeon may have even used a phrase like, we got it all. And then they send them on over to medical oncology, and the medical oncologist looks crazy because you say, oh, well, yes, your surgeon got it all, but you also need chemo. How are both of those things true? Someone's lying, right? And the problem is the surgeons can be very, very good, and they can be very, very thorough, but we all know in this room there can be microscopic residue, and a cell left behind is a cell that over time will have the chance to grow. So this to me is an incredibly meaningful graphic. I saw this about 5-6 years ago at ASCO. Dr. Meyerhart presented it. What he's pointing out is in stage 3 colon cancer, many, perhaps half, perhaps more, of the patients are cured by surgery alone. But because not all of them are cured by surgery alone, we end up giving chemo or recommending chemo for all of them. So we're in this weird balancing act where we know actually we're over-treating, but we do that on purpose. So how do we get better? The other way I would present it to you, if you've ever kind of taken an ethics class, I had one in medical school, you may have heard of the trolley problem. It's a really interesting thought exercise. So the way this works is there's a trolley that's kind of barreling out of control, and if you don't pull a lever that's right in front of you, it's going to run over 5 people, okay? If you pull that lever, you know it's going to kill 1 person. So this is kind of like, do you just stand by and watch this tragedy happen, or do you intervene and then you hurt somebody? That is exactly what we do with adjuvant chemotherapy when we're pulling that lever. So here I would argue that what oncologists are doing is we have been doing is over-treating because we don't want to under-treat. Enter circulating tumor DNA. I think this is probably as close as we're going to get to solving this dilemma. So circulating tumor DNA, in my mind, is a better marker than CEA. We heard earlier today a very moving story about that gentleman in the Coast Guard whose CEA is in the thousands when it should be 3 or below. Here's the thing, though. You can actually have someone that's absolutely riddled with metastases, and their CEA can be 0. CEA is not a great biomarker in that respect. It can either be insensitive or it can be nonspecific. If any one of us get food poisoning, heaven forbid, our CEA will go up because it's not a colon cancer marker. It's a marker of bowel turnover. It's just because these cells start in the colon that the CEA rises. So I think this is a better marker. However, there are caveats, as with any new tech. So it's very accessible blood sample. It's stable. It's genomically characterized. It has a very short half-life, probably something like 30 minutes. And not only can you do a ctDNA test and say positive or negative, you can actually quantify it. So just like CEA, if you get someone that has a positive ctDNA, you can follow that hopefully down to 0. And once they're in 0, that's technically a remission. However, you can also see in the disadvantages column, some tumors just don't shed, like we would hope. And it's also expensive and it's new. And then finally, there's this problem of CHIP. So I practice in Utah. I'm in the youngest state in the nation. Median age is 30. The average age in my clinic, though, is 68. So in some ways, we can think of cancer as a disease of getting older, not exclusively, but sometimes. And the older people are, the more you'll pick up kind of their background noise. So CHIP, or clonal hematopoiesis of indeterminate provenance or potential, you can get these kind of false positives with ctDNA as well. And it's costly because it's new. We've also, for a couple of years now, maybe 7 or so, been looking at ctDNA as prognostic in colon cancer. So for instance, we've known that people that have no ctDNA signal postoperatively do better than people who have a positive signal. That just makes sense, right? If there's cancer left behind, it's going to come back and it is going to kill many of these people. But prognostic is one thing. What if we could actually use this and intervene and change these people's lives? Maybe their fate isn't sealed after all, and that's what you can see here. This is a remarkable study shared by our Japanese colleagues at ASCO GI. Over 1,000 patients enrolled, which now we do have a very robust sample size. What I want you to see here is in the red, this is stage 1 through stage 4 colon cancer. The patients who have a negative ctDNA signal, they do great. That survival rate is almost 100%. So these are stage 4 patients where there are not too many weeds in the garden. So for instance, what might happen here is they have a liver metastasis, singular resected, their ctDNA is negative and they never recur. And we cannot miss those people either. This is interesting too. So this is answering the trolley problem. This is finding out who is actually benefiting from adjuvant chemo, who is not being overtreated. And what happens here is they were looking at, in that red line, the red line is patients with either high risk stage 2 or stage 3 colon cancer who received adjuvant chemotherapy when they were ctDNA positive. And you can see how the survival differs from people who were ctDNA positive and did not receive adjuvant, which is the black line. This is also interesting. What if there was an opportunity using ctDNA to not give chemo in the first place? This is an oncologist's dream. So what you can see here is these people who didn't have a ctDNA signal at all after surgery did just as well in the long run, whether or not you gave them chemo. So why on earth would you give these people chemo? You're just inflicting harm. There is one problem, though. This test is so sensitive that you can actually get a positive ctDNA signal more than a year before you can see something on the scan. This is the part I don't think we talk about enough. It's the psychological damage that we can inflict. So I have patients right now who have a positive ctDNA signal. I have no idea where it's coming from. I can't see it on PET, MRI, CT, you name it. And there is a real weight that comes with that. So before we rush out and do ctDNA on everybody, we have to acknowledge this. This is part of shared decision making. I was taught, as probably you were, don't do a test unless you know how to act on the result. And unfortunately, this is so new. This is maybe the biggest downside, is you'll have some people who are just absolutely terrified and they're waiting for their cancer to recur. And we don't know yet if we can save these people by giving them chemo early. So the Japanese colleagues I mentioned earlier are actually trying to address that question as well. So the Galaxy trial I mentioned is part of a larger umbrella. It's called Circulate Japan. And Circulate Japan had the observational trial, which is Galaxy. And it has 2 other arms that are basically based on whether or not you're going to act on the ctDNA signal. So let's start in the blue. The blue arm is very interesting to me, and hopefully to you. So this is the Vega trial. So this is taking people who 1 month after colon surgery have no ctDNA. It's randomizing them to do standard chemo, adjuvant Capox, or observation. So think about that for a second. You're telling someone that, hey, listen, we know the standard of care for colon cancer is to give adjuvant chemo. We're not going to do that in you because your signal is negative. This trial had to be done in Japan first for medical legal reasons here in the United States. But as I'll get to here at the end, we are running a study here in the United States that I want you to strongly think about for our patients. Because the only way this is ever going to work in the States with all of our litigation is if we have a trial showing that you can avoid or abstain from chemo in the ctDNA negative patients. Now, the Japanese colleagues are also doing the opposite. So if they're ctDNA positive after surgery, of course they're going to give those people chemo. This is the Altair trial. But then they're going one step further. After the positive patients finish a standard course of chemo, say 6 months, then they're randomized to either get placebo or trifluridine tipiracil. I'm not supposed to use brand names, but that's an oral chemo drug. And we are bringing it to the United States, and it's being done in a trial right now. And I know for a fact there are sites in Colorado that are enrolling. So this is NRG GI008. because oncologists love alphabet soup. You might also call it Circulate US. And this is interesting. This is going to enroll about 2,000 patients, so we should have very, very robust data. And again, I'll just show you the schema. So these patients get this ctDNA test after surgery. I'll focus on the negatives first. The negative ctDNA folks get randomized to, this is on the bottom of the diagram now, to standard adjuvant chemo or, and this is key, the green box, no chemo. Okay, American patients who normally would get adjuvant chemo not getting chemo. That's why I think this trial is going to actually be quite easy to accrue to, because I think patients will really like that option. Now let's look at the opposite. What if you're positive? If you're positive, you're randomized to the standard adjuvant chemotherapy, or you're randomized to chemo escalation, which is FOLFOX/CIRI. So we don't normally use irinotecan in the adjuvant setting. These patients are getting 5-FU, oxalate, and irinotecan. Watch this space. It's accruing right now. I don't know exactly when it'll mature, but I think this is going to change the standard of care in the United States. So to finish, we must uphold the bare minimum of testing for our colon patients, just like we would do for our breast patients. It makes zero sense for an oncologist to walk from a breast cancer patient where they know ER, PR, HER2 next door and just be flying blind with colon. That's completely unacceptable. The second thing, as I mentioned, is ctDNA is great, but there again, it requires shared decision-making. We owe it to the patients to say, hey, listen, we don't really know everything about this technology. We think it's better, but we're learning. And I think being honest about that, sharing the uncertainty, acting honestly that we're not omniscient, I think that's key. I think that's absolutely the essence of shared decision-making. And then finally, and this is key, never been closer to first do no harm. As an oncologist, as oncology nurses, and anyone in this room, it's virtually impossible for us to uphold that. It's the first standard of medical ethics, and it's the first one that we violate. And if we can use ctDNA, we can abstain from chemo, treat the right people, and not over-treat the wrong people, then we are being authentic to our number one ethical principle of first do no harm. With that, I'll close. I'll be happy to take questions. Thank you.
Do we have any questions for Dr. Lewis?
That was such a brilliant talk. Thank you so much.
It was the accent, but that's fine.
You're right. I did get a lot more interested after you switched it on. So you talked about a little bit of like the psychological burden. I mean, is this something that you see ctDNA, not necessarily taking the place of scans, but like when we talk about like surveillance and survival and things like that, is that also something that they're looking at?
Absolutely, actually, great question. So one of the things I think that ctDNA can do is actually relieve us of the burden of scanning quite so frequently. The thing I often tell my patients is when I'll be very transparent with my training, both where it was and the timing. So I trained at Mayo between 2009 and 2012. Mayo Clinic's a great place. But if I practiced now the way I was trained then, it would be malpractice, all right? Because what I was taught is, Mark, if you're going to follow these people, they need CT scans every 3 months for 5 years. That is a ton of radiation exposure. Each one of these CTs is roughly 200 X-rays, right? Just stacked up, and the computer puts them together. So do the math. That's 4,000 X-rays over the course of 5 years. That's enough to give 2% of those patients another cancer while we're looking for the first one. That's ridiculous. That's idiopathic harm, or iatrogenic harm, excuse me. So to answer your question, I think one of the promises of ctDNA, and you've absolutely hit on the worrying part, but what about the reassuring part? What if it actually helps me know, actually, this person doesn't need a scan right now, or probably doesn't? I think that's probably the better aspect of it. Where we go counseling them psychologically, I don't know yet. Again, I think it's important to be honest up front that if we get a positive signal, that triggers a scan. And by the way, it's usually a PET. I didn't go into this, and I don't use PET scans that routinely, but there's a group from Denmark that showed that if you have a positive ctDNA signal, your best way to figure out where it's coming from is a PET scan. And even then, the best case scenario is you see a single liver met, you cut it out, the signal goes to 0, and then they do just as well as if they never recurred. Other questions?
Okay.
All right.
Thank you.
Thanks, guys. Appreciate it.